The aim of this video is to make sure that we get the word out of the importance of pre-entry notification in EMS.
Down 68 to the Home Depot on Willie Street for the stabbing.
The entry notification should be short. They should present the information that is most important to act on immediately, and it should not be such that it overburdens the people that are taking the information.
We're there in 30 seconds.
In various regions, the entry notifications are done all the time versus entry notifications being done on certain types of patients, but there are a few entry notifications that are incredibly important. Those include trauma notifications, those include stroke notifications, those include myocardial infarction or acute coronary syndrome, ST elevation, MI notifications, and those are the time-critical emergencies that really require us to be prepared in order to give the best and most efficient care to your patients. If you have a protocol in place and you use a protocol, there will be less of a likelihood for you to forget something or for you to misplace some of the information. And if we develop a protocol, that allows us as a group, as a collaborative, to figure out which things are the most important to be provided and the order in which they're provided, which definitely makes a difference. It's also important to recognize that the hospitals in which you're transferring patients to for a higher level of care need to be notified as well. And one of the confusions often is that although you're picking a patient up at an outside hospital, bringing them into a tertiary care center, and that communication between the hospitals has already taken place, you can't assume that we know exactly when the patient is coming. Trauma patient, a trauma transfer, some patient that's going to require a higher level of care, it would be great to hear about that patient 10 minutes before so that we can notify the people that need to be notified. The blood bank, the trauma team, the anesthesiologist, all those people need to be notified so they can gather so we can take the best care of your patients.
The first patient I ever saw in the United States with severe trauma had driven his car into a tree at 110 miles an hour.
So sure, this is motorcycle versus telephone pole. We have a 27-year-old female. Passenger was helmeted with cracks in the helmet. Helmet was off upon arrival.
We know, New England Journal 2006, that if you are severely injured, like that first patient I saw, and go to a level 1 or a level 2 trauma center, you have a 25% better chance, a better outcome of surviving that injury.
DCS is 8, 80/60 is her blood pressure.
Lower than 90 systolic, that means the patient's lost a significant amount of blood. They're bleeding from somewhere, often internally, sometimes externally. And that should alert the EMTs and the paramedics that this should go to the trauma center, and they should be able to call through the communication system and say, this is a severe trauma, and then the hospital will activate the trauma team.
Patient is unresponsive. Patient now is being air moved.
In many cases, taking that patient to the right place and activating the trauma team, it's the operating room, it's the anesthesiologist, it's the neurosurgeon, if they've got it, all of the team is ready to go when the patient arrives. If you go to the level 1 or the level 2 trauma centers, they are ready to go, 24 hours a day, 7 days a week. And it's just a matter of notification, which we get from our EMTs and paramedics, and they're there to greet the patient, and all of the amenities, operating room, blood bank, etc. are ready to go 24/7, and that's what makes the difference.
Right son has now been decompressed, and we'll see in approximately 15 minutes.
Put just a little bit more resources up front, but the payoff in terms of survival or decreased disability is absolutely enormous. Absolutely enormous.
The most important thing I need to know is, do you think it's a stroke? And how certain are you? And I want to know the timing of the event. When was the patient last known to be well, and when were their symptoms first discovered?
This is P1. We're currently coming to your facility with a 59-year-old female. Patient was found in chair by family member, listing to the right, facial droop to the right.
After I hear that, I want to know about factors that might predispose to stroke. Is this a person with atrial fibrillation? Is this a person with a seizure disorder? So I can think about the likelihood this is a stroke and what medicines are they on. If they're on Coumadin, chances are they may not be eligible for TPA. I might be thinking about firing up the endovascular team.
She does have a history of hypertension, AFib, and is diabetic. She is on Coumadin.
The benefit of TPA decreases exponentially. So treatment within 60 minutes of the start of the stroke is 2 or 3 times better than treatment at 3 hours or 3.5 hours after the stroke. So the earlier the better.
Can you grip my hands?
And a lot of time is being spent getting to the patient from the time of dispatch, spending time on scene assessing the patient, and getting them back in the ambulance to drive them to the hospital. We'd like to hear about it as early as possible, not when they're 5 minutes out.
She was last seen normal 3 hours prior at breakfast.
If their stroke is very disabling, if they're aphasic and hemiplegic, meaning they can't talk and they can't move one side of their body, then I may be calling in my endovascular team.
You know, there's a number of different point of entry protocols that we see in the Massachusetts state treatment protocols. Probably the most well-known is STEMI, point of entry for STEMI, or ST elevation MI. And those are patients who are having ST elevation MIs that are identified by paramedics on 12 lead EKGs and subsequently require transport to a PCI capable hospital. That's a hospital that has a cath lab open and available to do emergent PCIs 24 hours a day, 7 days a week.
Vitals are 90/54, heart rate's 96, she was 92% on room air.
The most important thing when we're talking about STEMI is, hey, I'm coming in, I have a STEMI. I know you know how to read an EKG. I know you know how to identify a STEMI. I want you to tell me it's a STEMI. I don't want you to call CMed and say, this is paramedic whoever, I'm coming in with a 54-year-old male who was shoveling snow and then he had chest pain. I want you to say, hey, this is paramedic 2, I'm coming in with a STEMI. Boom. Then you can tell me the rest, but by the time you said STEMI, everyone's perked up, everyone's listening to the rest of the story, and I'm already downstream activating my cardiologist and activating my PCI team. And the evidence at this point is saying that if I can get that patient to the cath lab and we can open up that blood vessel that's blocked and causing the heart attack in less than 90 minutes, those patients are going to have a significantly improved mortality.
In the burn patients especially, it can be difficult to tell the age, so they should start with the age, sex, what happened and when. So let's say explosion at 2 o'clock in the afternoon while the patient was drilling his furnace.
Coming in with a 27-year-old male, was involved in a home fire. He was in bed, was smoking, fell asleep, and the bed actually caught fire.
For burn patient, time is critical in terms of calculating the fluid resuscitation formula. We know that fluid resuscitation is probably the hallmark and the holy grail of proper burn care. And it's the first, typically 24 to 48 hours, that very often define the rest of their hospital stay.
About 15% total burns, which encompass the left hand, which looks like a first-degree burn.
The house burned down. He ran out of the house or returned for things. Inhalation injury. We're looking for clues. Could they have spent time inside of burning building and how long it could have been? Because the injury to the lungs is not apparent, not visible. There's no good diagnostic tests. Of course, the assessment, how big percentage of body they feel the patients are burned, what exactly was done to stabilize the patient. Typically, more extensive burn patients are already intubated, so information related to IV lines, tubes, and so forth, and then whatever else they may have done since the injury.
And listen to his breath sounds too.
We need to know just about every little detail about how the injury occurred. Was it in closed environment? Was it outside? Was it highly flammable liquid like gasoline versus something like paint thinners? Are there associated injuries, trauma, explosion, were the patients thrown off, fell off, jumped off window? And of course the chemical burns, what kind of chemicals, and they're phenomenal in bringing always the data safety material sheets so that we can not only exactly know what's going on, but very often the recommendations are there for early management. And then finally, electrical injuries are very unique, specific, but very, very dangerous because the high voltage injuries can not present superficially as much, but cause tremendous burn in the deeper tissues. And knowing the circumstances of the injury is very critical.
We have intubated that patient.
But we had a young man who was about late 20s at the time of his injury, who was working on his car, drained gasoline from the tank, but unfortunately started drilling metal not far enough from the container with the gasoline, which exploded in the garage, and he got almost 90% burn. He was sort of a patient where you want to know exactly how quickly he may have gotten from the garage, who else was there, what else was going on. Explosion could be associated with additional trauma. So when he came, we had the full story. We could treat him immediately from the information we got, and he ultimately actually ended up surviving. One additional piece of information that we were looking for, especially in elderly patients or children, is potential clues for abuse. There are unfortunately still patients that sustain burns that are very unusual in their location. If it's an imprint of an iron, doesn't sound like it could have been an accident. So we're looking for signs of domestic violence. But those are sort of the cases where we feel like it's a true partnership to get the needed information right at that moment when they arrive.
CMED's role, certainly here at Metro Boston CMED, is to allow ambulances and hospitals to communicate with each other. That's its basic function. And we also play a role in disaster management, interoperability between ambulance services in various cities and towns.
Remember, we deal with over 60 towns, all the way out past 495. It could be anywhere, even helicopters coming across the water.
The vast majority of ambulance calls within and outside the city, within the region, do not require a hospital notification or medical control.
Boston CMED, this is South Shore Paramedical One requesting notification entry for the Brigham and Women's.
We average about 4,000 or 5,000 patches here a month. All the ambulances in the state are required to have a CMED-capable radio, and there are 16 designated radio channels that we use. There's a hailing channel, so everybody who needs to talk to a hospital will hail CMED, and our folks up here will answer that radio. Then they will ask us, tell us whatever it is they need. Do they need, a patch to a hospital just to give them some information, or do they need to talk to a doctor and get medical control?
We do have the ability to notify if there's a physical plant problem with the hospital. They've lost electricity, they've lost phone. We can divert on those kind of things.
CMED's real function is to allow the EMTs or the paramedics to give the hospital a heads up, so that if they're bringing in a particularly ill patient or a trauma patient, they can give that information to the hospital to allow them time to mobilize their resources to get everything ready prior to the ambulance arriving at the hospital with that patient.
So medical control is part of the statewide treatment protocols. There's online and offline medical control. And offline medical control is your protocols. If this, do this. If that, do this. But you'll see at the bottom of every protocol, or at the change of every different scenario, is if you continue to have this condition or you have this question, contact medical control.
Medical control, dispatch desk, please. Medical control.
I think in most cities and towns, certainly here in Boston, our EMTs and paramedics train with Boston Medical Center. Our medical control physicians are there. We have medical control physicians on staff that are emergency room doctors too. So they're involved in our training in the beginning. They're involved in our continuing education on a regular basis. And I think that holds true in a lot of the community hospitals as well. Their ambulance crews are in there all the time. So they have a relationship with the nursing staff, and they have a relationship with the physicians. So there is a level of trust that comes with that.
What do you got?
Doc, got a trauma coming in, looking for medical control for some meds, I believe.
If you call CMED on a radio to give a point of entry note, for example, a tone will signal in our emergency department, and that's basically an entry note tone. If you're looking for medical control, a different sound will occur, and that kind of just perks everybody's ear up that maybe there's something more serious, or you need a physician or a medical control physician to the phone to answer a question. Medical control, Dr. Tollefsen, go ahead. We give you orders for additional medications. We give you guidance about whether or not a patient really needs to come to the hospital. If you're having issues with a psychiatric patient, for example, and you say, you know, I'm really concerned, I think they need to come to the hospital, we work with you to section that patient if need be from the streets. You need orders for an additional sedative for a patient who's being transported and intubated. That's what medical control's for, and we're happy to answer those calls at all times of the day.
When we talk about point of entry notification between field providers and EMS in the hospitals, mass casualty incidents, MCIs, pose a very unique situation compared to most of your single patient encounters. When we talk about notifying hospitals for MCIs, we're really talking about notification for resources.
An
MCI communication, we're notifying the hospital, the healthcare system really, beyond just a single hospital, that a major incident's happened and that the healthcare system needs to mobilize its resources. And that can mean a lot of things. We experienced this on the marathon of 2013 after the initial explosions. Within 3 minutes, CMed was notified of a major incident.
We had a lot of critically injured patients who needed a lot of real high-level care, but you can't bring all of those really severely injured patients into a single facility. We knew how many patients there were, we knew how many patients were going to each hospital, and we knew kind of the level of their severity.
Help up from the medical tent. Get as many people up here as you can from the medical tent.
That triggered a lot of downstream actions by the hospitals. As first receivers, we want to clear the emergency department. We want to look at our surgical capabilities. We want to look at what we have for bed resources. If we have patients who can be quickly discharged or moved from one care area to another to be ready to take in the patients coming from a scene, it helps the EMTs, the field providers, because it allows them to kind of move through the response process without anything delaying patient care, simply because of numbers.
In MCIs, we classify patients as red, green, or yellow. So a red patient is the most severely ill or injured. Yellow is injured or ill, but not immediately life-threatening, and then green patients tend to be walking wounded type of patients.
We transported overall about 118 patients from that incident, and amazingly, patients were distributed in a fairly balanced fashion. And that's a key component for CMed and the hospitals to manage, because the field providers are busy enough dealing with the scene. It allows the field providers to utilize their incident command structure on who is going to manage the transport aspect of the disaster, and allow them to divvy them up, if you will, to the available resources.
Walk to the corner of Wing and Huntington. And walk that road, get through. We're going to need more ambulance there.
You know, despite the disaster, people are still going to be calling 911s. People are still going to be accessing EMS for the things that are not related to the disaster. And this is where a coordinated communication for mass casualty incidents play a vital role in the overall response.
One of the key aspects of anything, but especially in emergency medicine, is the teamwork that goes on between the pre-hospital providers, the hospital providers, and the in-hospital providers. Having entry notifications for patients, especially from trauma, from having a stroke, from having a heart attack or an MI, really makes a big difference, because those extra minutes in the hospital, the time that they can take to prepare before the patient arrives, can make a difference, not just in life and death, but sometimes the long-term outcome and how well a person lives their life afterwards. One of the things the hospital is able to do when they get the early notifications is they can bring specialized teams to the emergency room. They can have teams of people meet them in the ER, and sometimes not even stop in the emergency room, and take the patient right to the definitive treatment in the hospital. For the EMTs and the paramedics notifying the hospital, one of the critical things they can do is be short, sweet, succinct, give the key pertinent information that the hospital needs to make that important decision on who to call in and where to call the staff to take care of the patient. Quite often when the patient that survives, recognizes the hospital personnel that do great jobs and truly make a difference in people's lives, but it's also the EMTs and the paramedics that sometimes put their life on the line going in to try and save somebody's life, whether it's from a car accident, from someone who's been shot or stabbed, and putting themselves at risk. Thank you to all the people that make a difference in the system. And the system is made up of the people who answer the initial call for help, the 911 operators and the dispatchers. It's also made up of the first responders that go to the scene. It's made up of the EMTs and the paramedics that take care of the patients. It's made up of the people who at the hospital receive the patients, the doctors, the nurses, but also the aides, everybody that's part of the system. During EMS week, I think it's really important to say thank you, because how many jobs make a difference in somebody's life? And these are jobs that truly make a difference in somebody's life. So it's time to say thank you. Take a moment, thank yourself, thank your co-workers, because it is a team that makes a difference to save people's life.